My name is Ocean Lifeguard Stefan Leon Jr., and today's presentation is based around the skills that we don't often use as EMTs or lifeguards, but nonetheless are very important skills to have. The skills that we will be talking about today are those in which we assist ALS. Knowledge of these skills can mean the difference between rapid and prolonged treatment for our patients. So how can we help? Ways we can help is by giving a detailed report to our medics once they arrive on scene. Now, why do we assist ALS? We assist because faster treatment can lead to better patient outcomes. Or if we're ever in a situation in which we're in a rural area, our call car or our captain are delayed, then we should know how we can assist our medic. What are 3 common ways in which we can assist ALS? They are as follows: intubation, IV access, and ACLS monitoring. First, we're going to talk about intubating a patient. So knowing when a medic will intubate a patient is very important. They may do so when a patient is in cardiac arrest, respiratory arrest, traumatic arrest, drug overdose, persistent seizures, or respiratory failure. What we can do is we can clear the airway of any obstruction, so remove any emesis, any food, or any type of foreign body. Next, we can ask which French size or tube size the medic would like. Then we can take a 10 cc syringe, attach it to the tube, and then deflate this balloon here at the end. Once that's done, we can open the packaging for our stylet. Just make sure you keep it sterile. Then we can ask our medic which blade or laryngoscope type they would like. This here is a curved blade. This is a Mac blade. We also have a straight blade or a Miller blade. Once the tube is in place, we can go ahead and inflate using this syringe. We'll inflate this balloon, and then we'll further secure the tube with cloth tape to the face. Once that's done, we'll go ahead and attach a BVM to this end here with 100% oxygen and bag the patient, or our medic may ask for us to listen to bilateral lung sounds. Next thing we can do is assist with IV access. As a phlebotomist, I'm very comfortable with gaining venous access. So what we're going to do is we're going to remove the garments. This is the antecubital region here, forearm, wrist, and hand. We'll remove garments from all those areas. And then our medic will go ahead and apply the tourniquet and warm the site if need be. And then they'll also grab their preferred gauge for the IV. What we can do is we can attach a lure lock to a 10 cc syringe. So this is our 10 cc syringe with normal saline, and our lure lock or extension tubing will just push all that air out. Or we can spike the bag using this end into one of these holes here, squeeze the bag until all of the fluid has run through this tubing and there's no more air. Any residual air will cause an air embolism in our patient. Next, we're going to want to make sure that this tubing remains sterile, so we'll go ahead and recap that tubing. Any dirt can lead to an infection in our patient. Lastly, we'll secure the IV using Tegaderm or any tape. Lastly, we're going to talk about assisting with cardiac monitoring. As lifeguards, we use the most basic form of cardiac monitoring with our AEDs. So assisting ALS with any type of ACLS can free them up so they can treat the patient for more dire issues. So there are 4 types of leads that we use in a pre-hospital setting. That's 3, 4, 5, and 12 leads. That's these here. So we're going to talk about the 5 lead and the placement of the electrodes. This is the right arm. That's going to be placed on the right side mid-clavicular at the first intercostal space. This is the left arm. It's going to be placed on the left side mid-clavicular at the first intercostal space. This is the left lower. It's going to be placed on the left flank. Right lower on the right flank. And then the 5th electrode is going to be placed at the 4th intercostal space on right side of the sternum. 4 and 3 will have similar placements, just fewer electrodes. Lastly, we're going to talk about our 12 lead cardiac monitoring. This is done when there is a suspected myocardial infarction, and this will give us a better reading for what the heart is doing. Placement for those electrodes are as follows: V1 on the right sternal border at the 4th intercostal space. V2 is going to be placed at the left sternal border at the 4th intercostal space. V4 is going to be placed at the mid-clavicular area at the 5th intercostal space. V3 is going to be between V2 and V4. V6 will be placed at mid-axillary region at the 5th intercostal space. V5 will be placed between V4 and V6. And then we have right arm, right leg, left arm, left leg. And those are going to be placed on the forearms for the arms, the quad region for the legs. And these are all attached to cardiac monitors. And these are 3 ways in which we can assist ALS. Are there any questions?